Who's already here to our July Community Engagement Forum. We'll give folks a few minutes to transition from their other meetings and things before we get started. I'm going to give it one more minute here, watching the participant counter creep up. Everyone's having a good day so far. All right, so I'm going to go ahead and jump in and get us started. We'll start just with a few of these shameless commerce slides. Our next community engagement forum will be in October on the 23rd, and we'll have more details about that coming out, but we'll be highlighting a couple of our current or former CCTSI Community Engagement Health Equity Pilot Grantee Partnerships. Just a reminder, if you're interested in consulting with our group, you can reach out directly to Mary Fisher, or we have a web form, excuse me, web form that you can complete to request a consult. And I mentioned our pilot grants, our request for application release is going to be at the end of October. It says coming soon, and the way how fast the summer's gone, yeah, it'll be coming soon. And we have all of our previous community engagement forums available on our website. You can link to it off our CCTSI website. I think you can also link to it from the Accords website as well. And just a little bit about our partners, the partnership here between Accords and CCTSI. Accords is your one-stop shop for pragmatic research, and lots of great resources available at Accords for folks doing all kinds of outcomes research. Great team there. And our education program seminars will be returning in the fall. So you want to make sure you're on that list. This is one of those, qualitative research workshop, led by the super talented qualitative research team at Accords. So if you're interested in qualitative research, it's a great program and workshop. Now I'm going to move into a little bit of just a recap of our April Community Engagement Forum, which was in person. You can see the names and logos of the community organizations that were here on campus with us, manning tables and sharing some of their work and partnerships that they've had with our campus. It was really, really a great event. Super well attended, and 100% of folks who responded to our evaluation said they'd be interested in attending a future in-person forum. Vast majority of the attendees agreed that presentations from campus leaders were useful to their current or future work. 83% found it helpful to connect with community or academic partner they'd not met before. And well over half found a community or academic partner they'd like to work with in the future. So that felt like a real success for us, and we're looking forward to repeating the in-person forum next April. And I'll just transition from that by saying, yeah, our evaluations are something that we really take seriously, thanks to those who fill those out, and we really appreciate that. Today, we're starting a new series, From Principles to Practice, Engaging Underserved Communities for Multi-Level Impact. And many that completed the evaluation from our April showcase had suggestions on topics for future forums. One of those was somebody said they were interested in resources for rural underserved areas. So that's really relevant, helped us decide on our topic for today. We really appreciate that kind of input, and hope that this is useful for everyone. Underserved, that's a term that was intentional in the title. Just want to make sure that language can always sometimes be a little bit challenging, but we really wanted to emphasize that the lack of access to services is a structural kind of thing. It's not really intended to blame or shame any particular community or anyone in a community. We're really trying to highlight data about how long it might take to receive access to care, the limitations that exist with that, long wait times, et cetera. So that is going to be our focus today in rural Colorado, specifically a program that started in rural eastern Colorado. Want to encourage you as we're moving along today to put questions into the chat. We'll be monitoring those, and there will be time at the end of the presentation by our COMET presenters to have some discussion around those questions. So with that, I'm going to pass the baton to Adrienne Miller. Adrienne is our community advisor for our community engagement forums, and Adrienne works with the Colorado Council of Churches, amongst being famous for other things as well. So Adrienne, great to have you with us today. I'm going to pass it over to you.
Thanks so much, Don. Good to be with everyone, and it's my pleasure to introduce our panelists for today. So first, I will introduce Chris Bennett. Chris is an emeriti member of the Community Advisory Committee, part of the High Plains Research Network in Eastern Colorado. Chris was raised in Lyman, Colorado, and graduated from Lyman High School in 2010. He attended the University of Colorado Boulder on a Betcher scholarship and received both his BS and MS in aerospace engineering. After graduating, he and his wife, Caitlin Bennett, moved to Pasadena, California, where he worked for NASA's Jet Propulsion Laboratory. Chris was a systems engineer supporting multiple Mars missions, including the Curiosity rover, Mars Relay Network, MAVEN, and Mars Sample Return. In 2019, Chris accepted a position as a systems engineer with Maxar, which allowed him and his family to return to Westminster, Colorado. Chris first started volunteering with the High Plains Research Network in 2007 for the Eye on Health project as a high school mentor. While working on that project, Chris developed a passion for the community-based participatory research methods that are the core methods of the High Plains Research Network. The High Plains Research Network brought valuable evidence-based practices and made them approachable and applicable to the unique communities of Eastern Colorado. Chris joined the HPRN Community Advisory Council in 2008 and has since supported many different projects that have improved the health of rural Eastern Coloradans, including projects on colon cancer, asthma, COPD, hypertension, cancer survivorship, CBPR methods, boot camp translation, and mental health. Also joining us is Sadie Fitzler. Sadie is the research coordinator and practice facilitator for the High Plains Research Network in Northeast Colorado. She is a native of Sterling, Colorado, with 10 years of experience in career and technical education and higher education student services. She has provided representation on Banner's Health's hospital transformation program for Sterling Regional Medical Center and served on the Patient Advisory Board for Northeast Colorado Family Medicine. Sadie works with primary practices, public health, and community organizations on HPRN research and quality improvement and practice transformation projects to support the health of Eastern rural Colorado. And we also have Linda Zittleman. Linda is the director of the High Plains Research Network. With HPRN, she oversees all aspects of research and program activities and fosters and coordinates the HPRN Community Advisory Council. With a background in public health, Linda is experienced in community-based participatory research and practice-based research. Linda greatly enjoys working with people on the Eastern Plains and informing urban folks of the knowledge gained and the new ideas from rural settings. So welcome to all of you. I will turn it over to you and look forward to moderating questions after your presentations.
Great, thank you so much, Adrian. And on behalf of Chris and Sadie and myself, just thank you for this opportunity. We're very excited to be able to talk with you about our work in Eastern Colorado and specifically the COMET program. And in a few minutes, you will see how all of Chris's background actually really plays a big role in COMET. But I'll let the anticipation just bubble up for that. So I'm going to share my screen here. And I want to be sure this looks good. I get a thumbs up just to make sure people can see this. Okay. Well, I'm going to kick us off and just by starting with a brief disclosure. We don't have anything to disclose. I do want to point out that Chris, Sadie, and I are not mental health experts or care providers. You've heard our backgrounds, and that's who we are. So before we jump into much, though, I want to give us just a little more context about our work and who we are. So as you've heard, we are all affiliated with the High Plains Research Network, and probably some of you here today have heard of this, but some of you may not have. High Plains Research Network, or HPRN, is a practice and community-based research network. It works with primary care practices in rural Eastern Colorado, as well as community members and organizations. Over the years, we've also worked with hospitals and public health departments and others in the region, depending on the project. This covers a 16-county region, as you can see here on the map, that green section. really all of Eastern Colorado, usually the flyover area of Eastern Colorado. The High Plains was established in 1997, so it's been around for a while, and our academic and administrative base is in the Department of Family Medicine at the University of Colorado. An important aspect of our work is our partnerships with community members, and we have a community advisory council that, as you've heard, Chris has been a part of for a long time. This was established in 2003. And it's a very grassroots group. It consists of farmers and teachers and ranchers, students, home health providers, business office managers, people who know what it's like to live and work and seek healthcare in Eastern Colorado. The Advisory Council really guides the work of the High Plains Research Network, and members have significantly contributed to really all aspects of the research studies and projects that we do. And this includes identifying priority health topics. In fact, we create what we call a top 10 list of priority health areas that we really refer to guide our work. And we'll talk a little bit more about that in a minute. I think, Chris and Sadie, is there anything else you wanted to say about yourselves, or should we jump into our talk? Okay. So the approach we've taken today for our talk today is really to present the COMET story. We'll describe what we did and why. And then there will be time for questions at the end, so you can ask more about the details of some of those whats and whys. But we'll spend most of our time telling the story of how COMET was developed, how we're disseminating it, and our hopes for next steps. You might notice that through this talk, Chris and Sadie and I might be a little interactive. We might jump in and add things here and there. So just know that that's how we're going to approach this. Let's just start by saying what COMET is. So COMET, again, stands for changing our mental and emotional trajectory. In a nutshell, COMET is a community-based intervention to improve community members' ability to help others successfully access mental health and emotional health care or support, especially before a condition becomes an emergency. So just, we'll get more into the specifics in a minute. But we want to go back and, again, thinking about the story of COMET, we're going to go back in time. COMET starts a long time ago. We're going to go back to 2013. And as I mentioned earlier, there's that top 10 list that the Community Advisory Council creates. Mental and emotional health was always on that list of priorities. That list is influenced by a mix of learning about data, but also people's experiences. And that's the case for COMET. Mental health was called out as a priority. Some of those statistics, excuse me, that's a hard word to get out today, is that a lot of people in the US, about 20% of Americans have a diagnosed mental illness. But on top of that, there are even more people, an additional estimated 25%, who suffer from distress that may go unrecognized or undiagnosed, but still has significant impact on our quality of lives. Thinking about this experience in rural Eastern Colorado, there are fewer resources in many rural communities across the country, and that is true for Eastern Colorado. Fewer number of healthcare providers, mental health and emotional health care providers, and other resources. There are also some barriers that people experience in rural areas, such as transportation issues, insurance, and stigma. Also, in talking with our Community Advisory Council, we also recognize that there are some wonderful existing resources, but a lot of them focus on that crisis end of the spectrum. Suicide prevention, very, very important, but there's a whole range of need that often goes unaddressed. And with that, I want to turn this over to Chris for him to jump in and say a little bit about where he was coming from years ago, and then to walk us through how COMET came to be.
Yeah, thank you. So yeah, I think one of the important things we'll be working through this presentation is just the timeline and how long some of this took. This was back in 2013. I was at that time in college, but worked with the Community Advisory Council back when I was in high school, and I worked at a restaurant there in Lyman, Colorado. If any of you have driven through Lyman, that's usually the only way people know Lyman. And there's lots of restaurants in Lyman, and I served tables at a restaurant, and it was a slow day, late summer. We had a harvest worker come in. He was part of the harvesters who kind of come through in work crews, and he was just having a slow day. Like the day before, they had a lot of rain. They were waiting for the land to dry out before they could go back out with their combines. And so he just came into the restaurant. He was hanging out, and he was there. He started at lunch. By the time lunch rush ended, he was the only person in the restaurant. I just sat and talked to him, and it was interesting. I barely know this guy. We're just chatting because we're both in this restaurant, and it's just the two of us. And he suddenly our conversation takes a very sharp turn into like how lonely being a traveling harvester can be, and all the mental health issues that he's had. And he was from, if I recall correctly, he was from like Western Kansas, so very close to Colorado. And we had a lot of kind of shared experience growing up. So talking through that and it just really made me realize, again, this was a young man. I was 17, 18 at the time, and he was probably 22. So we were pretty close in age, but just that age gap and having him explain kind of this crisis of like loneliness and kind of the mental and emotional load that he was under as he was working in these small communities in Eastern Colorado really struck a chord with me. And I remember going back to the CAC and I kind of brought it up, and as we were discussing this issue, everybody kind of had stories like this, right? From the community members, like, oh, I'm close with this family member and they're dealing with this mental health issue right now. This is 2013, so mental and emotional wellness was still significantly more stigmatized than it is even now. And so we were kind of pulling on these threads and realizing that all of us had direct experience with how this intersected with large fractions of the community. So, we had always had this mental health and behavioral health as a priority health issue. Like Linda said, it was on our top 10 list. And one of the challenges is there's just a lot. Mental health is a wide field, right? Covers so many things. And so we really felt like we needed to just learn more. And we did a lot of kind of bringing experts out, probably some from this forum. We've engaged with many experts over the years to come out, and they just taught us different topics, right? We learned about the major diagnoses and policy issues and insurance and integrated behavioral health care. So we had a lot of different conversations, but we kept coming back to so much of the work was not where we could affect it, right? We can't change, as community members and researchers, we're not going to change insurance policy. We're not going to change, kind of the macro system issues. And we kept coming back. And then, on the other side of the pendulum, the clinical systems in clinical settings where the major diagnoses were happening, we're also not really going to affect those, right? And so this is a great example, this whiteboard here, of we really kind of laid everything out, and we just went through and we're like, yeah, this isn't it. This isn't where our group is going to move the needle, right? And you can see we had a lot of conversations. This was challenging. I remember, for those of you who know Jack, at one point, Jack Westfall was like, oh, well, why don't we focus on depression in older male farmers? the highest suicide rates in our region. It's a known issue. It's well supported in research and funding. And I remember the community council just being like, yeah, that's important, but that's not what is resonating with us right now, right? We were really stuck on like, how do we get all of that 25% of people who have an undiagnosed condition? How do we get those people into receiving care before they have a crisis? Like, that was really the genesis of COMET, was focusing on, get people access to care who are not in crisis and before an emergency, right? And really affecting the whole general population, not a specific target audience. So that's really kind of where we narrowed in on what we wanted to focus. And like I said, just getting there was a process. So I don't know, Linda, Sadie, if you want to add anything through getting to our thesis.
No, I think that's great. Oops, I'll go back.
Yeah, so then we ran into the next challenge. A lot of times when we are looking at a research problem, we're looking for, and especially in mental health care, right? Everybody talks about barriers. There's barriers to access, barriers because of insurance, barriers because of travel. And that became a lot, every conversation we started in mental health would turn into, well, we have all these barriers, and like we could focus a whole lot of energy on removing one barrier, but there's 20 more behind it, right? And I still remember one of our community advisory members, I remember her just sitting there and being like, if there's all these barriers, how does anybody access the system? And it kind of flipped the question, it like flipped all of our brains upside down when she asked that, right? We were like, oh, people do successfully access the system. And we kind of like have a bias from how research is conducted with the hyper focus on the barriers. And so we kind of used a method that our group has used in the past, which is called appreciative inquiry. And we were like, why don't we focus on what is working? How is it working? For the people who do successfully navigate from, distress pre-crisis into successfully accessing care, how does that work? How does it work for them? Is there a consistent pattern for how it works? Or is it stochastic random error that they can each get in successfully? And so, we just very simple prompting question. We used our networks in the community, the people we knew from those stories that kind of kicked off everything. We reached out to them and we asked, tell us the success story. How did you actually access mental health care? And, it was a small sample, 29 stories from 21 people. We did have a pretty good distribution across the population. And so that's really kind of our first method set of how did we get raw data. Do you want any other follow-ups here, Sadie or Linda? Nope. All right. So then it was funny because Dawn, I saw you talking about the qualitative research group at the beginning of this presentation. We did use, we had some experts come in, help us with that qualitative research translation. They did a lot of coding of the interviews. And then we, as community members, sat shoulder to shoulder with the coding results with the researchers, and we went through the results. I remember this, as a community member, people are always surprised how sometimes our community members just get so excited to engage with the raw data and like be part of the research process. And this is a place where I remember just being so excited to kind of be there, seeing as a group, right? I think, Linda, I think you and Jack had just gotten the results like a couple of days before us. And so it really was kind of all of us absorbing the conclusions together, right? And we did 3 in-person meetings, we did multiple conference calls. This was over 7 months. And we were just kind of hammering through the themes that were consistently coming through, right? And so that was a very rigorous part of the process that I think it's easy to brush over. Like, oh, we did some research, we got some data, and we came to conclusion. I know that's probably routine for everyone else, but this is one of the places where the community was deeply involved in that component. And I think it's important to how our eventual product was developed.
Can I jump in for 1 second, Chris?
Yeah.
Some of you here might be familiar with a process called boot camp translation. It's also sometimes called community translation. We're not going to get into the details of that here today, but it is a process that actually grew out of the work of this group in Eastern Colorado on previous projects. So that's the process that we used to guide this taking of this evidence that we gathered from our local community members with those interviews and translated that into something that we thought would be meaningful and relevant for Eastern Colorado. Yeah, as Chris said, it's very simplified here on the screen, but a lot of work went into that. I'm having trouble advancing, so it seems like I have to do this. There we go.
Yeah. So one of the really core concepts that really popped out of all of the interviews is this idea of the other person. And really, when we thought about it, this went back to all of the original stories that kicked all this off, right? Unwittingly, I had played the role of the other person to this random traveling worker, this traveling harvester. Just someone who often you have no direct connection to. They're not in your immediate circle. That a person in distress talks to, and that person, this is also another critical thing, was almost never clinically trained to handle mental health. They were just another person. And then the other thing that really popped out is like the safe venues where these conversations happened. If you grew up, this is one of those things that when people think about their community, these things are obvious, right? You know, there's sometimes in a small town, it may be the parking lot of the gym where all the high school sports are happening, where people are just interfacing multiple times, right? It could be the bar, like the restaurant where I was working. It could be the church. These safe venues, and these safe venues were not really clinical. Again, a lot of this success stories started not with clinical experts and not in clinical settings, right? And you have this barrier to access. And this is where all the barriers stack up. This is where we have well-documented research that these barriers stack up between the person in need and that provider and support. And we realized that there was always this other person in the safe venue that was redirecting them. Where we saw success, that's where we saw success. And that became kind of one of the core tenets of COMET. And this is where my background as an aerospace engineer kicked in. So this is the shameless plug of, one of the things that really stuck out to me as we're talking about this, this person, the other person here, had no clinical experience. They actually didn't do much clinical helping, right? And what really stuck out to me is it's very much like gravity. We're just being present, just being there. You redirected someone's trajectory from going towards crisis back to receiving care and wellness, right? And this concept of, I don't have to be an expert. My wife is a social worker. I'm married to an MSW. I don't have to be an MSW with years of experience in this. I just have to be present and available, and I can redirect someone back to receiving proper care successfully. And this is something that especially some of the older members on our community advisory council were like, yeah, our society used to be very good at this, but always in very specific communities. Like people, that's where in small towns for a long time, like churches were the foundation of these communities. And a lot of, you know, in the modern era, like some of those communities haven't sustained this cycle as much. And so, you know, some of the younger generations aren't used to this. They're not used to how to be that other person. And so that's one of the things that stuck out to us. Yep, so here you can see, this is part of that process of the BCT of really taking that, now that we had our themes, our ideas, how do we actually generate a health questionnaire? How do we actually get to training people to do this well? And so this is just kind of brainstorming some of the methods. I mean, this is just, you can see some of the raw products as we were through that process. Did you have anything here, Linda? Otherwise?
Yeah, I'll just quickly say, you can see here, we're now in 2015. So some time has passed. And as Chris was saying, this question was, how do we help people to be the other person? And this is where the CAC took what we had learned from our appreciative inquiry, but also blended that with their own lived experiences and said, how do we talk? What would we say if we wanted to actually engage in a conversation that could be potentially difficult to initiate? And that's really where COMET, what COMET is. And I will, advance here, and then we can show you the actual specifics in a second.
Yeah, and so this is where kind of our final product ended up being a conversation guide. So something that you can quickly train standard general population to help the end with, you know, messages focusing on community responsibility, permission to ask, and methods to refer people to the appropriate services. How do I get from untrained individual back to that clinical success setting successfully? And that's really what the product ended up being. So I think we can jump in and actually look at the product at this point.
The only thing I'll add, Chris, is that kind of deep conversation. We talked a lot about being like not being the fix, and how the community members said, you know, we want to activate people. This whole permission to ask was really big. We want people to know they can do it, but we also don't want people to think they have to be little mini counselors and be responsible for, you know, someone's outcome, if you will, if they need a little bit more help than a person might be able to give. So that's where this, how do I help someone who might need more help came into play. And you'll see that here in the COMET questions.
Oh, sorry. Okay, I was making sure I was unmuted. Yeah, so here's kind of the core questions we got to. And this is, a lot of this comes from that coding, right? So like one of the very common themes in those original conversations was just acknowledging someone is not themselves. This one always sticks out to me. The number of times we say, how are you, but don't mean it. That was very common. And in a lot of the success stories we saw, someone took the time to like, no, really, how are you? Like, you're going through a hard time. I know this is happening. How are you really doing? So it was that second follow-up that often unlocked the conversation. And then this was, you know, from motivational interviewing kind of practice of like, share an observation, right? I've noticed you haven't been to the basketball games recently. You haven't been here. You know, how are things at home or school or work? So, you know, kind of this basic kind of pattern that is pretty standard for kind of getting someone to open up and giving them the permission to open up. And then here's the invitation to engage, right? Can we get coffee sometime? And then this is where we were very clear with we wanted the conversation to get very clear that we wanted to give the other person permission to, you don't have to self-disclose. I had a similar situation once. Is very useful, but also, sometimes that's not the best step. And so making sure people understood that was a choice. And then also, asking how to help more or exit the conversation, redirecting them with the appropriate references in a healthy way. So that's kind of what the final product ended up looking like.
Well, I'll just quickly add that the column on the right gives you just a sample of one example. The actual full COMET conversation guide includes multiple examples of things people could say under each of these 7 areas. But that gives everyone a sense of how this came to be. And now Sadie's going to kind of quickly walk us through what we're doing to get this out the door. And then I'll just wrap up with next steps and we'll move on. Oops.
All right. So how do we get coming out the door? So like Chris said, we've developed this product. We have these questions. Now, what do we do? So the group created wallet cards, and those are just simple cards that fit in your wallet. They're the size of like a business card that have the questions, and then on the back have resources for the community. And so a big part of the training we spend on developing this list of resources, not only statewide, but what are some local resources should a person need a referral or someone further advanced in mental health care than you are. There's resources available, and it's just something they can have in their desk drawer and their wallet to carry around with them. Part of the dissemination process as well is just engaging groups within the communities in the work. And so a lot of the work that we do is really community driven. Our community advisory council finds a lot of the trainings that we've done. And it's very community focused. It's very much we really want to help our community and what are ways that we can do that. So we asked ourselves, will people know how to use the COMET wallet cards, and will it have credibility, and what will people think of it, and how will they respond? And so this training was developed really a lot by a CAC member who worked in education and really guided the principles of education. And when training someone, what are some primary focuses? So it was designed again with simple language focused towards any and all community members that could attend. Initially, the conversation was had is how long do we want to have the training? Because there's a lot of mental health trainings like mental health first aid that are out there, but they're 8 hours long. And we found that that's a major barrier. People don't have the time to put in an 8-hour training. So really develop this training to fit within a 90-minute window. The program itself is a lot of information and then some practice guided along with it. And so the participants that are in the COMET training, they get the information, how does COMET work, and then they actually practice with one another. Over time, and I think even recently in the last year, demand is increasing exponentially. I think mental health is on the forefront of a lot of people's minds. So we kind of developed this hub and spoke model, tapping into knowledge and expertise of local people across the communities. And so we host what are called train the trainer workshops, where we have trainers that are certified and equipped to conduct COMET community trainings within their own local communities. So we set aside this group. We just did one recently in Hugo, and we set aside this group. It was like 10 people, and these 10 individuals came from all walks of life, but they all wanted to be able to give COMET to their community. And so we do this train the trainer workshop, and then these people that are trained are able to go out into their communities and provide the training for their communities. We do have a core training faculty team, which includes CAC members, HPRN staff, CSU Extension, Agribility, and Southeast Health Group, now known as Valleywide Health System. So we do have a core faculty group that does the train the trainers. But really there's trainings happening all over within communities by people that have attended this train the trainer workshop and are able to go out into their communities and provide the COMET curriculum.
Well, and you see here, going back to our timeline, we started the Train the Trainer workshops in 2020. As Sadie said, demand has increased, especially in even more recent years, but you can see kind of the time that has evolved since we first started talking about COMET to now it really getting out the door. So where are we now? Just to wrap up here, a little snapshot, those community trainings. We've had, at last count, at the end of June, 198 have been conducted, almost, well, a little over 2,300 people that we have record of have attended those. And this is not only in Colorado, but across the country in 11 states and Honduras. COMET is available in Spanish, just for the record too. And the workshops, we're increasing the number of those. We've conducted 24 of those Train the Trainer workshops, that hub and spoke model. And those have happened in about 8 states. And again, that we want to call out how that model aims to recognize the expertise and the knowledge that local community members have to do these, to disseminate COMET in their communities, where Sadie, Chris, and I would not know that. So it doesn't make sense for us to be doing those community trainings. Looking ahead, how are we continuing to engage with our community partners and make sure this is staying true to that original vision? As we mentioned, one of our community members with experience in education, that was her career teaching at community college, is our curriculum director, as we call it. Our training faculty, again, are people with from rural Colorado who have incredible knowledge and can really tap into different ways to disseminate this program across Colorado and beyond. Our community advisory council members have presented COMET all over the place, actually, in Colorado and national and international meetings. They support the writing of manuscripts. They help get information out to local newspapers. And really thinking ahead, one thing we want to do is continue our conversations with our community partners and our training faculty to look at our evaluation results and think about what do we need to tweak potentially. And another big thing that will be the last point I make here is recognizing that we have a lot of transition. So both with the community partners, but also with our whole team. And over time, we will have more transitions. And how do we take this resource that was created with community members and sustain it in a way that supports program fidelity and helps us remain true to that original vision? And then we are continually aiming to try to find funding to support this program work. And with that, I'll say thank you and we'll stop. Thank you very much.
No, thank you so much, team. That was really, really interesting stuff. We have about 5 minutes or so for questions. So as you answer questions, we have some rolling in. Just keep that in mind because we want to get to as many questions as possible. First of all, Chris, I'm going to avoid the obvious "this isn't rocket science" joke given your background. So I will say this with the appreciative inquiry. Thank you for a positive framing of AI. Thank you so much. All right. First question is, and maybe Sadie, you can speak to this. What were some of the surprises as you started to do the dissemination?
I think finding your key players in your community kind of surprised me. So for example, here in Sterling, we did, one of the community advisory council members reached out to the owner of the sale barn here in Sterling and said, hey, we have this program about mental health. I know you're passionate about mental health. Would you mind hosting this program at the sale barn? He's like, absolutely, let's do it. Well, after that COMET community training at the sale barn, he went to every single bank in town. He got like 10 signed up immediately to do the COMET training. And it was just based on one community member attending a training that was then able to go out into the other communities and say, here, you should do this. I've done it. Now you should do it. And you don't have an excuse. And so he really got a ton of people on board. And I would say just from that one community member, we've probably trained over 100 people in COMET just from his involvement. So that was really surprising and kind of cool, I think.
Okay, quick follow-up. What is a sale barn?
A sale barn where you take your cattle to sell them. So cow calf sale every week, typically in the fall, calves are being sold. And so they go and auction cattle at the sale barn, and they auction other things. They do like equipment sales and things like that. But yeah.
Okay. Yeah, so through this presentation, I noticed that you all were, first of all, you cared, and then you were doing active listening. And then it seems like your team had a collaborative environment, right? That people felt that they could offer up ideas. To use one of the buzzwords of the days, it sounds like you all were doing design thinking, where you were doing outside the box and trying to approach things in innovative ways. And then this is really community driven, which I think is, and felt organic. And I think that helps with the buy-in that you all have. So with all of that in mind, like how would you advise people to engage in this work with diverse backgrounds, with people when you have limited broadband, older adults, veterans, those with complex care needs, LGBTQ plus, bilingual, various second language capabilities? Like, how do you juggle all of that? Any advice?
Adrian, are you referring to just like community partnerships in general, not specific to COMET, but yeah.
Yeah. Well, either one, whichever one you think
Okay.
would be more illuminating. Yeah.
Yeah. Chris, not to put you on the spot, but I'd love for you to start if you have any initial thoughts about what you think has worked in this work and what are some of the challenges, and then I'm happy to chime in.
Yeah, I'll start with potentially a contentious point, which is this was a long, challenging process for both the community members and the researchers, right? And we were able to navigate that because this group has been together for a long time, and we have a lot of trust and rapport built up. I do see if you tried to tackle a problem like this as your first task with a community engagement group, I can see that very challenging. There was a lot of times in this process where, we were just like, we don't agree. Like, we're not on the same page. And we had enough relationship and rapport built up that we can kind of like work through that and get to a point of like, oh no, this is what we can, this is the foundation of what we agree on and where we want to build the solution. So I think that is the biggest difference to me. But Linda, curious from your perspective.
Yeah. Yeah, I think communication is huge. Both communication during our meetings when we're together, but also in between. So staying in touch with people, sometimes doing that reaching out to people one-on-one in between meetings to continue discussions. Chris really brought up an important point of if you're newer to this approach to your research or your work, don't start with the hardest topic. Have those early wins and really celebrate what you do accomplish together and what you've done. But I know that sounds very simple about the communication piece, but that's so huge. And I think it addresses a lot of what you mentioned, Adrian.
Okay. What about outreach to high school students? Have you done things that say like assemblies or anything like that? Can you share any lessons there?
We've had some good conversations about COMET and its fit with youth. I think some community members are really wanting to use it and have. We also have said we've had some experience with it just needing a little refined approach. One of our colleagues has said, you might need to think about how you have an initial conversation around mental and emotional health with youth or older teenagers, and then get into what COMET actually is. So I think it can definitely work. Might just need some laying the foundation.
Yeah.
Okay.
Some of the feedback I've received as well from people that have done trainings with adolescents and minors, there's a huge consent process to make sure the parents are aware. And the other thing is to make sure that every adult in that student's life is aware of the program and knows how to answer questions in relation to the program. So there's a lot of training involved with the adults within that adolescence community to make sure that they're able and capable to help that student should something come up.
Another question, and this is kind of collapsing two questions, but there some people just wondering about how you get funded, or what kind of suggestions you may have for getting funding for this type of work.
Yeah, funding there's always that tension. I think overall, when we think about our how High Plains has approached its work, we often talk about that tension between the community priorities. So in our case, that top 10 list, and what's being funded. What are the funding agencies actually funding? And it kind of goes like this. It's never this. So again, I think having those ongoing conversations about how this type of work, how research works, like we are dependent on funding, is really important with your community partners. And the approach we've also taken is we are not picky. We don't need an NIH grant. We will take money from wherever. And for COMET specifically, it's been a challenge, I will say. I honestly think COMET may have been a little ahead of its time early on, way back when, and we continue to look for funding to support the program. We've done some in-kind work. We've developed a business plan, if you will, to cover some of the expenses with this, but it is a challenge, and I think just persistence, just need persistence.
All right. Well, I'll go ahead, Chris, real quickly. Yeah.
So just on that same topic, because we were talking about like the easy wins earlier and that overlapping list. It is actually really important, I think, to have a list. Like, you're not going to hit the one topic you care about, and neither are the community members. And understanding that, like, here's 10 things we're interested in working on, and here's 3 opportunities. That's really how you get through some of those early wins. So I just want to emphasize, like, tying the 2 questions together there.
All right. Thank you so much. I'm going to turn it over to Sarah Brewer to close us out. But please, in the chat, will you show some love for Chris, Linda, and Sadie for all that they've shared with us today? Thank you.
Yeah, and I want to echo that. Thank you so much, Sadie and Chris and Linda, for coming and sharing this really amazing program you guys have put together, and particularly for highlighting the methods and the process that you guys took to get there. I think really I was impressed with the various different ways you were able to think about your community's priorities, to use some novel methods to engage folks across your community, and the really impressive HPRN infrastructure that you have built to be able to do that. So thank you so much for sharing that with all of us. For those of you who are still on, I would love for you to take a minute to complete our evaluation. Jordan put it in the chat a little bit ago, but maybe we can get that link back in there. As we highlighted at the beginning, we really appreciate your feedback and your ideas for the Community Engagement Forum, and would love to hear from you. I want to acknowledge we did get some questions from folks in registering for this that didn't quite fit our discussion today, but we are paying attention to some of those comments and suggestions you've made around how researchers can leverage different partnerships and think about engaging in community engaged research, and then how people can be involved in managing more complicated care needs in low-income communities. So those things are on our list, and we want to appreciate you sharing those in the registration. And then lastly, I want to share our recording will be out in the next day or 2, and you can access those on the Accords website or the CCTSI Community Engagement and Health Equity site. And save the date reminder, our next Community Engagement Forum will be October 23rd, and we really hope to see you all there. So thank you all for being here today, and thank you again to our presenters for chatting about COMET and your wonderful process to get to the program you have now. Thank you so much, and thank you all for being here.